name symbolized all that was corrupt to society. His name symbolized all that was pure. And I was being held in the embrace of a man who was pure. Think of what it is when God himself puts his arms around you and says, welcome home.
Good morning, everyone. May I ask you to sit down, please? Good morning, everyone, and welcome to the third edition of Geneva Digital Health Day. I want to say hello to everyone here in Geneva, but also to the many people that are following and registered for joining us online. It's wonderful to see so many familiar faces, but also new ones. And for those who I haven't met yet, my name is Dr. Perrin, and I'm directing the Geneva Digital Health Hub. At gdhub, our work is about connecting the dots between knowledge and action, between policy and implementation, and between different domains. So essentially between the people that speak about digital health and the people who have to make it work. And that's exactly what today is about, connecting different domains, connecting different worlds. Public health and technology, research and implementation, policy and practice, startups and large institutions. And of course about listening, learning and staying curious. And they say third time's a charm, so you're in luck because today is our third edition. We had quite a few lessons to be learned from the first two editions, but because of that, I hope and believe we have a perfect day ahead. And we are starting perfectly with an opening keynote by Dr. Alain Labrique, who's the director of the Department of Data, Digital Health, Analytics and AI at the World Health Organization. And Alain and his team have been key partners in the journey of gdhub and GDHD. And we are very grateful for the collaboration with WHO and the Global Initiative on Digital Health. But before I hand over to Alain, I want to take a moment to thank the team behind GDHD, so the core team of gdhub, the incredible team who made this possible. So Awa, Sophie, Alexi, Aziza, Mirana, Mahmoud, and of course the big boss, Antoine. Thank you so much. We're a small team, but everyone in our team is so motivated, cares so much, and so full of passion. So it's really a pleasure and a privilege to work with all of you. I also want to thank our volunteers who keep everything running behind the scenes, including some of them who are back for the third year in a row. So there's something we must have done right the last 2 years. And of course, I also want to thank all of our partners for their trust, their continued support, and their long-term partnership. Alain, you've been a friend to Geneva Digital Health Day from the very beginning, and we are honored to open with you today. So I invite you to come on stage, and the floor is yours.
Good morning. I think there hasn't been enough coffee flowing. Let's try that again. Good morning. Ah, there we go. I tried that with ministers yesterday, and it also worked. It woke them up. So this is fantastic. What a privilege to open Digital Health Day with this community at this moment. Dr. Perrin, Dr. Gispeler, or actually now I should refer to you as Big Boss Antoine, I just learned. So we've come such a long way, and in a really short time. I actually want to start with a round of applause for everyone who's brought us together, because as you say, it's a huge amount of work to pull this off. So bravo to the team who's done all the work behind the scenes. Our own digital events at the World Health Assembly began on Saturday, which in WHA time feels like 2 months ago. But we've had 42 discussions, side events, policy dialogues on just data, digital health, and artificial intelligence. And that's more than double the number from last year. In the last 5 days, no fewer than 30 ministers of health, global development bank leads, and major philanthropies have not just spoken about the shiny promise of digital and AI in global health, but what they've done is affirmed the clear role of systematic, deliberate investment in digital transformation, in digital infrastructure and standards, the core features of their health systems. And that, ladies and gentlemen, is a radical change from the discourse that we've heard for the last 20 years. In the many years I've been working in this space, and it's around that same number, I'm sad to say, I never imagined that I would witness ministers standing up and using words like interoperability and semantic standards. And it's just refreshing to see that the kind of dialogue that's the bread and butter of many of you in this room today has now escalated to the level of the senior-most leaders of governments. But before I say any more, let me pause and have a word from my boss, my big boss, Dr. Tedros Ghebreyesus. So if you can cue the video. I'm not sure if I'm supposed to kneel or, or bow.
Digital transformation is one of the hottest. Excellencies, honorable ministers, dear colleagues and friends. Digital transformation is one of the hottest topics in global health. But digital transformation is not about applications, platforms, or devices. It's about how health systems serve people more equitably, more effectively, and with attention to every community. When designed well and implemented responsibly, digital health works. Health workers have better tools and better information. People can access and carry their health records securely across facilities and borders using WHO's international standards and platforms. And governments can track spending, measure progress, strengthen accountability, and ensure resources reach the right place at the right time. As artificial intelligence reshapes how people learn, connect, and make health decisions, we must ensure these technologies expand access, counter misinformation, and reduce, not deepen, inequities. But digital tools alone are not enough. They require governance, interoperability, cybersecurity, sustainable financing, digital literacy, and above all, trust. Countries must lead their own digital transformation through national strategies, resilient systems, and digital public infrastructure that's locally owned and sustained. That's why renewing the global strategy on digital health mattered so much. It affirmed that data, digital health, and artificial intelligence are interconnected pillars of stronger health systems. Together, we're making progress. More than 120 countries now have national digital health strategies, and over 2 billion people can access verifiable digital health records. As countries continue to undertake responsible digital transformation, WHO will be with them every step of the way to harness the power of technology for a healthier, safer, and fairer world. I thank you.
Thank you, Dr. Tedros. And for those of you who are filling out the digital health bingo cards, I think you got many of the key words there. You heard interoperability, sustainability, and most importantly, equity. But I want to begin with a crisis, because a year ago today, at Digital Health Day 2025, I shared an alarm. Over 40 countries had reported major failures in their digital health and health information systems. Patient records were lost, care was disrupted, HIV patients were missing their results, and mothers were losing their antenatal history to a cloud outage. And this was not just inconvenient, it was life-threatening. These weren't just accidents. They were the predictable consequences of a fragile, externally dependent system, built on pilots, funded by projects, not owned by countries. And when the funding stopped, the system stopped. And that crisis was a wake-up call, because countries that were affected were surprised, they were angry, and many have committed not to ever let this happen again. And something extraordinary happened. Countries stopped waiting. The global community stopped pretending that the old model was working. And a fundamental shift began in just the last 18 months. This was ratified in Accra, it was anchored in Lusaka towards digital health that is, as Dr. Tedros just said, nationally owned, nationally governed, and built to last. And the question WHO is hearing from countries over and over is no longer whether we should build health systems and whether digital is needed. That debate is over. The question now, and I see my colleague Sean Blaski from UNICEF is out there, and we get these questions from our member state governments all the time, is how do we build these systems right? What is that architecture that we need to have in place so that that doesn't ever happen again? And the answer and the inspiration is already visible. Look at Rwanda. Patient, consistent investment in people, in systems, in government at a time when even Rwandans were questioning, is this really what we should be spending our money on? And that has now paid off over years, not just quarters. Digital as infrastructure, not as a project. And look at Tanzania, look at Indonesia, India, Brazil. These are countries that made a political decision to build digital public infrastructure as a national asset, focusing on identity, focusing on canonical registries, interoperability standards, the roads and highways of modern, person-centered health systems. But also, and this will resonate hopefully with many of you who come from academia, it is a health system that's unafraid of data. A health system that's unafraid of politically inconvenient truths, but one that is geared to address those truths. And when you build those foundations, something remarkable happens. The benefits go beyond health. Digital public infrastructure serves education, social protection, financial inclusion. It becomes a tool of equity across sectors. It becomes a tool of inclusion and a tool for justice across every sector of national life. And that's the power of getting the foundations right. My team, I see several of you out here, are sick of me talking about foundations, 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 but we can't build the edifices of innovation that we hope to build unless we invest in those robust foundations. So the sea change that we're witnessing is happening right now at WHA, and this WHA 79 is significant. Ministries of Health, global leaders, celebrating digital public infrastructure is no small accomplishment. Using the words open standards, digital DPIs, and rejecting non-conformant disease-specific projects. So these are not pilots, this is infrastructure. The stuff that's invisible and underappreciated, but absolutely necessary if we want to make progress in this digital health that we've been speaking about for so many years. Now let me move to a caution. With generative AI, we face a temptation. Enthusiasm, proliferation, 100 tools promising transformation. Few connected, fewer still governed. Did this sound familiar, Sean? What's the word that we always hear in these meetings? It starts with a P. Anyone? Pilotitis, there you go. We've seen this before, right? 20 years of digital health, 20 years of pilotitis, and we're still treating the wounds. But countries have told us clearly, they don't want to repeat the mistake with AI. Yesterday in a session on AI governance, we heard the Minister of Health of Somalia talk about their intentional investment in digital transformation, but then he said something shocking. He looked at the audience and said, Somalia is intentionally not scaling digital as a national asset at the moment. The reason is not because we don't want to do it, it's because we know we don't have the regulatory and policy foundations to govern it well. And that, my friends, takes political courage. And it was phenomenal to see that being said by a top health official of a member state. So as we enter into the AI journey, what we're hearing is about tools integrated into architecture, not floating above it. That AI serves patients, policymakers, and providers, not just the inventors and the investors. Now let me close with a challenge, because a real digital health system shows you what's working and what is not. The underperforming facility, the supply chain gap, the equity gap between a wealthy district and a remote community. And we all know, because many of you have been in that room with the Ministers of Health or the Directorate General talking about the research that you've done and what it's uncovered. And that visibility is uncomfortable, but it's the foundation of a learning health system where no patient, no community is invisible. So we know how to build that kind of system. And so I ask each of you very directly, to the researchers and academics in the room, the world needs today your academic rigor, not just applied to discovery, but to implementation, to explore what it takes for proven solutions to work at scale, under fiscal pressure. So not just understanding the sensitivity, specificity, and impact of your technologies, but also the true costs of operating those models at scale. We need health economics that makes the case for the Minister of Health to go to the Minister of Finance and say, we need a budget line for this work. And that's the next frontier, and this community is poised to lead it. To those of you representing NGOs and partners, you may be building extraordinary things, but I challenge you to ask yourselves every day, how many of our systems can continue to exist without external funding? The measure of your work can no longer be at the coverage of a project level. It has to be about integration and the capacity that outlasts the project. And to the builders and implementers, very, very clear message. Please insist on standards. Refuse the shortcuts. Every non-standard system you deploy is a wall that someone else will have to tear down later. And it's always a worker or a patient that pays the price. The crisis I spoke about a minute ago showed us the cost of fragmentation. Rwanda, Tanzania, Brazil, India, Indonesia are showing us what patient-principled investment in foundations looks like. Digital public infrastructure built right is a tool of equity, of inclusion, and accountability, not just for health, but for everything that depends on people being seen, being counted, and being served. Health for all, as DG Tedros just said, starts with no one being invisible. I'm an epidemiologist, so we always like to start a conversation after we say hello, of course, about denominators. And if we don't have denominators, we can't talk about universal health coverage, because what is the universe we're speaking of? These challenges are not mine, they're not yours alone, they are ours. Let's face them together and build a healthier world. Thank you so much.
Good morning. Thank you, Alain, for the insightful keynote. It really sets up the day very well, and great that you pointed out the need for infrastructure, setting up the foundation very strong, because that's where everything lies. Without that, everything fails. So thank you for putting that up. Good morning, everyone. Warm welcome to the Track 1 sessions. We are gathered here at the intersection of technology, digital technology, and human resilience. The status quo in healthcare is no longer enough, and we are increasingly seeing interconnected ways of NCDs and mental health coming together. However, as Alain pointed out, there are lots of applications, lots of digital tools, which are unfortunately working as silos, and we need to break those silos. I'm Kallol Mukherji. I'm the digital health lead for Terre Homes, and I would be your co-host for this Track 1, along with my partner, Marina, who will introduce herself and take us forward.
Thank you, Kallol. Good morning, everyone. I'm Marina, Giachino, project manager of the NCD Policy Lab at the University of Geneva. And this morning, we will have keynote speakers, solution pitch presented, a panel discussion, as well as a speed dating session about NCDs and mental health. So now let's try to push a little bit beyond the buzzwords and really identify concrete steps that we can take to improve lives, but as well alleviate the systemic burden of our health infrastructure. Now, to start off this track, I have the pleasure to invite Professor Antoine Geisbühler, Dean of the Faculty of Medicine at the University of Geneva, for the welcome address. Please.
Well, thank you very much for the invitation and the opportunity. I also want to thank Alain Labrique for his inspiring talk, full of hope, full of caution, full of guidance. And I was struck by the fact that this is meeting number 42 about digital health. And as you probably know, in geek lore, 42 is the answer to life, the universe, and everything. Hopefully we will find some answers to difficult questions. Now, distinguished participants, colleagues, ladies and gentlemen, it is for me a great pleasure to open this session at the intersection of non-communicable diseases epidemic and the digital health revolution. NCDs, diabetes, cardiovascular disease, cancer, chronic respiratory illnesses represent the largest global health burden of our century, over 70% of death worldwide. And unlike acute infections, these conditions don't disappear after a single treatment. They demand continuous, daily, long-term management, constant monitoring, behavioral adjustments, seamless communication between patients and clinical teams. Against this challenge, digital health tools have emerged not just as an option, but as an absolute necessity. They hold the potential to shift our paradigms from reactive treatment to proactive prevention, from paternalistic medicine to true patient empowerment. But as we move from promise to implementation, we encounter the same systemic obstacles every time. The digital divide means that population most affected by NCDs are often the ones left furthest behind. Fragmentation means our tools don't talk to each other, creating floods of disconnected data that overwhelm rather than inform. Our health workforce, already stretched to the limit, too often finds that digital tools add burden rather than relieve it. Technology must serve the clinician, not the other way around. And the digital health graveyard is filled with successful pilots that fail to scale, because without sustainable financing and robust data governance, innovations cannot survive past their first funding cycle. We cannot open this track without addressing the elephant in the room, artificial intelligence. The potential is real, detecting diseases earlier, personalizing treatment, acting as a force multiplier for strained health systems. But AI amplifies every existing risk and adds dangerous new ones. Algorithmic bias can cement inequality into automated clinical code. Black box medicine means clinicians cannot safely act on recommendations they don't understand. And massive aggregation of sensitive patient data raises serious cybersecurity and ethical concerns that we cannot afford to ignore. We must design solutions that are not just innovative, but inclusive, interoperable, safe, and deeply human-centered. The challenge we face is no longer technological, it is political, behavioral, and organizational. It requires a shift from a culture of tech enthusiasm to a culture of tech responsibility. And that means learning from failure, sharing what works, making sure that we are not somewhere in the world right now repeating in countries 12 of the mistakes that we already made in countries 1 through 11. This is why the Geneva Digital Health Hub, or gdhub for short, has been created, bringing implementation and evaluation sciences and tools to improve the scalability, sustainability, and impact of digital health solutions. Through a collaboration between the University of Geneva, the Swiss Agency for Development and Cooperation, and the World Health Organization, and thanks to an amazing multidisciplinary team led by Dr. Caroline Perrin, it aims at closing the loop between implementation, real-world projects across diverse contexts, evidence, and policy, thus enabling strategic, tactical, and investment decisions to be informed by what has been measured and what has been learned. The gdhub does it through 4 areas of activities. First, science, generating actionable insight from the evaluation of real-world implementations. This is what academic partners, such as the University of Geneva, are about. And this is probably what is missing most to truly enable science-based policy and decision-making. Second, tools. We consolidate and develop open platforms like the Digital Health Atlas, which currently describes around 1,400 projects across 130 plus countries. And to translate such data into knowledge, we have built our flagship tool, the Implementome, developed in close collaboration with our partners. It is a living resource to ensure knowledge travels, lessons are shared, and no one starts from zero. Third, real-world implementations and evaluations. We use what we call digital outposts in several countries to test the tools at scale, generate further evidence, and bridge the gap between what we know and what gets done. And finally, communities, bringing together stakeholders through communities of practice so that they can learn from each other. And I'm so happy that today's Geneva Digital Health Day has now become, thanks to you all, a prime platform to bring our communities together and foster collective intelligence. I look forward to our discussions on how to build a digital health ecosystem that truly leaves no one behind. Thank you.
Thank you, Professor Gazbula. That was great getting us started. And thank you for speaking about both Implementon and the Digital Atlas. Those are great resources that has been built, and it's great use for every digital health user across the globe. Now I have the pleasure of inviting Dr. Rabi El-Shama, Head of National Mental Health Program, Ministry of Health, Lebanon. A psychiatrist and an advocate for mental health, Dr. Rabi has more than a decade's experience working on public health, refugee mental health, and mental health system reform. Today he will tell us about reforms to reach Lebanon's national mental health program in the digital age. Welcome, Dr.
Good morning. First of all, thank you, Caroline, Awa, and Sophie for the invitation. I had the pleasure of meeting you less than a year ago, I guess, in a digital meeting in France. And I'm happy that those discussions are happening, and I'm very pleased and reassured to hear the words of Professor Labrique and of Professor Gesserbeller, because from the implementation side, there are a lot of details that make things a bit more complex than what we hope they will be, because at the end of systems there are people as well, and institutions and ways of working that need to change. What I'm gonna talk to you about today, it's not mine. It's the work of hundreds of people, colleagues from WHO. I would like to name particularly Dr. Mark van Omren and Dr. Ken Carswell, who's here with me here in the room, ministries, colleagues, NGOs, UN partners, academia in Berlin and Geneva and Zurich and in Beirut. People who are working as e-helpers, supporting the apps that we've developed, operators that are answering hotlines in the middle of the night, community workers trying to link people to the systems. I'm here as a spokesperson for the National Mental Health Team, a great team that refuses to stop despite all the challenges that we face in Lebanon. Next slide, please. There are no slides here. Yeah. So 1 in 8 people globally live with mental health. In conflict areas such as Lebanon, it's 1 in 5. However, funding for mental health globally is less than 2%. In Lebanon, some studies show that there are probably, it was not a full national study, but about 60% of people suffering from some kind of mental health condition, and that was before the recent 2 wars, 2024 and the one right now. As you know, Lebanon has been through a lot of crises. It started in 2011 with the Syrian crisis, and Lebanon hosted 1.5 million refugees, then a big economic crisis, then a port explosion, then COVID, and then these 2 wars. This could have been a disaster for the system, but for the mental health system, it was actually maybe the reason why we started. Crises provided an opportunity for us to start. Yeah. What we're building in Lebanon is a digital mental health ecosystem, not an app. It started with an app, but it's growing to become something else just because the needs on the ground told us that an app on its own is not enough. I will talk about Lebanon not to hold it as an example, but to share with you what we've learned. Step by Step is a digital self-help application for depression developed with WHO and universities in different areas, now serving more than 6,000 persons integrated in the system. It has received the UN award in 2023, and it is free. Self-Help Plus, another WHO intervention that now is a podcast on a music app, and we're transforming it into an application and adding other languages like Amharic and Tagalog for the foreign domestic workers in Lebanon. The mental health information system that we're building aims to connect data from the PHCs and from the hospitals so we can have a pooled data about mental health. Bridge Mental Health is a platform where we will follow up all the workforces trained, supervised, who's here if they moved from one area, from one center to the other. And none of these actually work in isolation. Our aim is to really have this data inform each other and inform policy. A mental health app on its own is not a solution. I think we all agree on that. I say this as someone who has spent years working in digital health. We started working on Step by Step in 2017. And it took that much for it to become a service, like an integrated service, almost 10 years. Without a clinical pathway, an app is a cul-de-sac. A person improves a little, and then what? There's no one to refer them to, no data going anywhere, and no workforce to know that it exists. The lessons we've learned, sometimes the hard way, is that digital tools must be embedded. Embedded means inside a national strategy, connected to primary care with a trained workforce, data feeding national systems, and outcomes published. What does that embedded feels like? It feels like a lot of coordination meetings, a lot of calls, a lot of negotiations with actors who have different priorities, and then coming to a consensus that would work for all. But that unglamorous work is what makes something last. A system built within a national infrastructure, not floating alongside it. A system that survives funding cycles, changes in government. In Lebanon, we've learned that, and it can even survive war. This is the difference between impact that evaporates when the project ends and resilience built into a system that is there to stay. Here you can see the timeline of the National Mental Health Program. What does that timeline show? The red line is the is the crises. The blue line is the milestones that we were able to build. So it starts in 2011 with the Syrian crisis. After that, we did an assessment with UNHCR that showed that there are no coordination mechanisms for the MHPSS response. So that led to the establishment of the National Mental Health Program in 2014, then 2015 the strategy, then 2018 an independent evaluation of the strategy implementation by WHO, and so on and so forth. And in the red line, while we were building those, as you can see, we were responding to one crisis after the other. The last one is still ongoing. And how we were able to do that, I think, is transferable to other contexts. It's not magic. The element distilled in Lebanon actually can be summarized into the fact of having a governing body for the mental health system, which is the National Mental Health Program, who has the capacity to convene actors, to put them around one table. We have the mandate for that. Having created a coordination mechanism inclusive of other ministries, academia, NGOs, professional orders, where we sit together, we discuss the priorities, and then we divide the tasks and we report into what we've done. And having a roadmap, the strategy for Lebanon that is guiding us till 2030, but also the specific action plans for each crisis. And this timeline, I mean, I'll put a QR code at the end. You can go and click on the different milestones and learn more about the work that we've done. And having a system strengthening approach, using crisis as an opportunity also can be really a powerful catalyst for mental health system change. Interventions are really necessary, but the most determinants of mental health lie outside the health sector. Let's not forget that. And I think it's really important, especially in these times we live with war, displacement, climate change, AI-driven job anxiety, social media harm, especially for the youth, economic precarity. It's really important not to forget that and to keep advocating for those determinants to be addressed. So our collaboration cannot stop at the door of the health facility or within the health system. Peace advocates need to sit at the same table as digital health innovators. Climate researchers need to be in conversations with psychiatrists, economists with epidemiologists. Digital health gives us reach. Policy gives us roots. And a genuine partnership gives us the possibility and the power really to make change in the people that we serve. So where do we go from here? I think it's really important to remind ourselves that it's really important to view mental health not just as a necessary expense, but as an investment that governments can do for their social development and for the economic development of the people that they serve, and to consider mental health as a development priority. Second, think ecosystems that are built within national systems and serving national strategy. Do the work also, do the coordination, the unglamorous work. This is what makes the big difference. Third, I think we need to be sitting where the big discussions around the big social determinants are happening, whether the AI discussions, the climate change policy, we need to be there. We need to advocate and to get out of our technical areas and really push for what we think should be happening in those areas as well. And last, I think there's a lot of lessons that can be learned. And here the hub has, I think, a really major role to play by bringing us all together and, learning. We don't have to repeat what didn't work somewhere else. We don't have to repeat it. It can be summarized, it can be, disseminated, small meetings virtually happening, so the learning can be faster. And at the end, I will leave you with this QR code. You can go specifically to the last one where we've put all our digital resources, and you can check it. And we're happy to connect and to explore collaborations. Thank you again for this opportunity, and best of luck for the day.
Thank you very much, Dr. Rabi El-Shamay, for this insightful description of the work in Lebanon. We have so much to learn from it, definitely. I will now call on stage Lourdes Cruzado Castro, project manager at Crónicas, which is the Center of Excellence in Chronic Diseases at Universidad Peruana Cayetano Heredia in Lima, Peru. Lourdes will tell us about innovating diabetic food prevention, AI, and mobile health solutions from the Food Selfie project. The stage is yours.
Thank you for introduction. So, good morning, everyone. Today, I'm going to present our experience, Peruvian experience, innovating diabetic food prevention with the Food Selfie project. So when we think about technology development, it's difficult to think how it will apply for our community, for our vulnerable populations, and how to integrate in our health systems. So today, 1 in 3 people with diabetes will develop a food ulcer, and 85% of amputation present for food ulcers. So in countries, in low middle income countries like Peru, the prevalence for lesions increased up to 24%. So it's a public health challenges, and yet prevention remains out of reach. Why? Fragmented care, limited early detections, limited multidisciplinary care, and digital gaps. So the tools developed is designed for high incoming countries, not for our communities. In this context, born Food Selfie project. We developed an app-based AI for early detections in feet of people with diabetes. So we integrate 3 phases for the project. The first is the A training, the second is the co-creation, and the last is the pilot feasibility. For the first, we collected more of 12,000 photos from more than 800 people with diabetes in 5 public hospitals in Peru, achieving a 98% specificity and 81% sensitivity. So then, for the second phase co-creation, we included 54 stakeholders between people with diabetes, caregivers, healthcare professionals, and in 8 workshops in 2 sites in Peru, Lima and Piura. Lima is the capital, Piura is in the north of Peru. In this phase, the participants co-create an app from the logo and the name Alerta Pies in Spanish. So recommended different functionalities for the app. For example, include an educational component with information about diabetes food preventions, about mental health, nutrition, and others. For the camera, recommended to include a voice command for the take photos. And for the results, the participant recommended to include a lighting system with colors, with icons, to measure the risk of the lesions. So, and the other phase is the pilot feasibility. In this phase, we included 50 patients and follow-up during 12 weeks in 2 sites, in a hospital and primary health level. So in this phase, we are evaluating the feasibility, acceptability, usability, and engagement with the app, and also doing economic evaluations. So what we show, the AI works, it's possible to identify to pre-ulcerative lesions, and the co-creation is work too, the feasibility is underway, and also we formed a national advisory committee of 20 members with patients, with caregivers, with healthcare professionals, and decision makers during all the process of the project, and provide a technical brief to Minister of Health in Peru for include the technology and update our guidelines in focus in diabetes food preventions. So we have the data, we have the technology. I'm looking for research partners, implementation allies, funders and donors, especially for Latin America, and technology collaborators to improve the AI. So food selfie is not just a technology, it's innovation to close the gap in early detections for diabetes food prevention. Thank you so much.
Thank you, Lourdes, and teaching us our new position of selfie. Now I have the pleasure to invite Talia Salzman, Digital Health Specialist with Swiss TPH. Talia works towards advancing digital health technologies with special emphasis on clinical decision support systems. Talia will present about NCDs and mental health in the decision support system domain. Welcome, Talia.
Good morning, everyone, and thank you for the introduction. So every day, healthcare providers are consulting clients or patients who come to them with a wide range of needs, symptoms, and conditions. And in every care encounter, the healthcare provider has to sift mentally or physically through different clinical guidelines to ensure that they are assessing and managing the patient or client in the correct way. The number of guidelines and their interaction can get quite high and complex, in particular in the case of NCDs and mental health, where you often have multiple concurrent conditions. We know, in fact, that many times these guidelines, unfortunately, are not applied, resulting in low quality of care and poor health outcomes. 5 million deaths occur per year in low and middle income countries from this low quality of care, of which more than 2 million are cardiovascular disease. Specifically, a recent study in 38 low and middle income countries found that only 22% of cardiovascular patients and less than 10% of people living with diabetes were receiving treatment according to clinical guidelines. This low guideline adherence is not only a challenge in terms of health outcomes, but also in terms of equity, because patients consulting different providers will receive different care. Clinical decision support systems can help address some of these challenges. Clinical decision support systems can be implemented at any level of care. For example, community level, primary, secondary, tertiary level in pharmacies, for example. They can take many different forms. Here are just a few, such as alarms and prompts. They can be used on a mobile phone, on a tablet, on a computer. They can be standalone, or they can be embedded, for example, in an electronic medical record or in some other wider system. And they can be used in different parts of the care pathway. Again, here are a few. Now, we've been speaking in recent times very much about AI-based clinical decision support systems, so systems that are based on dynamic algorithms using machine learning. But in fact, already for more than 15 years, organizations have been developing what is called knowledge-based clinical decision support systems, or CDSS, which are based on static algorithms that are programmed from recognized evidence sources using if-then statements to directly reflect what is written, for example, in the clinical guidelines. In the case of NCDs and mental health, which are very broad disease groups, that there are some commonalities, in particular regular structured screening and regular follow-up, which lend themselves well to digitization. So there is a clear potential for NCDs and mental health, but we don't know what exists. There's no centralized database. So we're conducting a mapping of clinical decision support systems for facility-based care and LMIC, and of these, 12% are for NCDs and mental health. They are primarily at primary and tertiary level and in middle-income countries. The primary clinical areas are cardiovascular health, including stroke and hypertension, diabetes and depression, but we came across a wide range of use cases, such as drug dosing, checking drug interaction, either as standalone, for example, in rheumatology, or embedded in a national osteoporosis database, for example. We have tools to help support non-specialists with specialist decisions, such as insulin dosage in hospitals, or stroke subtype identification. So there's a wide range of applications. Unfortunately, and very much echoing what has already been said today, most of these studies were at prototype or pilot phase, and this means that we do not know if they were scaled, integrated into routine care, and if they have worked on the long run. So, through this mapping, we want to bring these different teams together, the knowledge accumulated in these different experiences, to identify what works and what doesn't. In particular, these studies often mention different implementation challenges, as well as variations in uptake. One study implemented in 2 countries and found in one country 85% uptake and one country 10% uptake. So there's really a lot to learn about this process of implementation and the different factors that mean that something will work or not work on the long run. So we will be bringing this together through the CDSS community of practice, leveraging, among others, the Digital Health Atlas to provide visibility and resources across these different interventions and learnings which will benefit future knowledge-based clinical decision support development and implementation, but also AI-based CDSS. Thank you.
Thank you so much, Talia, for this presentation. And now I would like to call up on stage Professor Florent Gluck from EPIA, and also working with the NCD Policy Lab, to speak about an aggregation system for a non-communicable disease platform. With a domain expertise of computer systems, Florent specializes in operating systems and systems programming. Please welcome him.
Mm-hmm. So thank you for the invitation. Hello, everybody. So I would like to start with a bit of context. This project, and the NCD platform, is born from a motivation by the NCD Policy Lab to build a portal that will gather all sorts of information on NCDs. The NCD Policy Lab's goal is to improve access to medicines, to access and technology in the field of NCDs. And what I noticed is that if you're looking for NCD information, whether it's articles or communications or any type of information in that field, in that space, it's quite difficult because there are tons of different sources. And so there's a motivation to gather all of these different sources into a single portal. So that's basically the motivation for this work. So we developed a web application that also works on mobile phones. So it's designed to be a hybrid application that displays on regular PC screens and smart devices. You can actually go on the website. It's ncdpolicylab.org, and then you can install it on your phone. So it has, I would say, two different types of content. It has a curated content that's provided by the NCD Policy Lab, where they publish events, reports, seminars, conferences, podcasts, and so on. And then there is an aggregator, which is a feed that's basically being populated every day. For now, it's only using PubMed, so it's collecting different articles and the research that's happening in the NCD space. And you have a bunch of filters. If you look at the screenshot at the top, well, you don't see very well, but there are a bunch of different filters. So you can filter by NCDs, you can filter by, say, education. So say you want to look for cancer in the field of education, you select these two fields, and in real time, it selects only the relevant information. And then you can also do a full text search on that to even be more specific, because there's just tons and tons of content. So you don't want to go through like hundreds of pages. So this is an ongoing project. So this is just the first phase. We have a short-term goal in mind, is to add new data sources. So this is currently being implemented. So we're going to add not only what we have already, but also Blue Sky, which is maybe you know of it. It's, I would say, an alternative to Twitter X, where people post different things. So we're going to integrate Blue Sky, we're going to integrate the WHO website, and then in the future, we'll probably integrate more sources. And we're going to classify these different sources to only keep what is relevant in the NCD field. And this is the, I would say, short-term goal. It should be ready in a few months. And then later on, we'll add, I would say, a summary. And we're going to try to extract only the relevant information to the users. Because despite these different filters that happen in real time, there's still too much data. And it's very hard to go through all these different documents. So the goal is to condense all of this and try to extract only what's really relevant to the user. So we're going to use also some AI models and tools to do text summary and maybe podcast. And also we want to deal with different languages, because not everything is in English. So we want to also translate everything on the fly to different languages using also machine learning and AI. So I think that's about it. Thank you.
Thank you, Professor. Now, to tell us about Open Tele-Rehab, expanding access to rehabilitation, I request Martin Jacob, Rehabilitation Technical Director in Humanity and Inclusion, to take the stage. Welcome, Martin.
Thank you. Thank you for the introduction. Thank you for the invitation and for the organization of the event. Very happy to be with you this morning. Good morning. My presentation will be about Open Tele-Rehab as a practical solution to expand access to rehabilitation services, which is a key strategy for NCD management. Maybe starting with setting the scene on NCDs and rehabilitation. We know that NCDs kill. It was mentioned earlier, 70% of all global death caused by NCDs. What we often tend to overlook is that NCD often and heavily disable. It's the leading cause of years lived with disability, and When it comes to disability, rehabilitation plays there a critical role. It helps people to be independent as possible. It helps people to participate meaningfully in society, going to work, going to school. And without rehabilitation, patients face preventable disabilities, they lose productivity. So there is a huge gap, a huge unmet need. This need is growing due to the rise of different health conditions and NCDs. And there is a huge need of access, since in many low and middle income countries, more than 50% of people do not receive the rehabilitation services that they require. So Humanity and Inclusion developed Open Telerehab, which is a solution that helps rehabilitation, but also healthcare providers to identify, refer, and deliver rehabilitation services remotely across the full care pathway. So this comes as an opportunity to reduce out-of-pocket expenditures. We know that traveling back and forth for these rehabilitation treatment takes a lot of time and a lot of travels. It's also an opportunity to support efficient use of available human resources, which we know are limited in many countries. It's an opportunity to promote continuity of care, improve follow-up, improve healthcare pathways, and it's also an opportunity to enhance data collection, reporting, analysis, and dissemination of different health and rehabilitation programs. So what is the software about? What is Open Telerehab about? It's a software made for the whole rehabilitation pathway. We have different portals, an admin portal for health systems, but also implementing organizations that will help them manage the content of the system, permission usages, system settings, etc. We have then the heart of the software that is a healthcare portal that will allow rehab professionals, but also primary healthcare workers to manage patients, manage treatment plans, organize the follow-up, the communication. And it will also empower primary healthcare workers when trained to deliver basic rehabilitation package services, and there we're leveraging the WHO basic package for rehabilitation intervention. And then finally, we have a mobile app that will allow patients to access treatment plan, to complete activities, communicate with their primary and rehab providers. And then the same mobile app is also used for primary healthcare workers to manage patient assessments, referrals, and follow-up. So it's a provider-to-provider software, but also a provider-to-patient software. The software is built to scale and integrate in real-world context. I mentioned already about the delivery of care remotely, patient management, treatment plans, remote communication using messages, voice, and video. We focused a lot of efforts on reaching the hardest to reach with an offline mode, support in local language, compliance with the WHO ITU accessibility standards for telehealth services, which, by the way, we contributed to. So really, we designed that for use in low resource and remote settings. It's also designed to integrate with health systems. It follows interoperability standards. It's leveraging a decentralized administration feature, and also built-in monitoring and evaluation tools. And then finally, it's designed to scale sustainably. It's an open source product recognized as a digital public good. It's developed using microservice architecture, and therefore comes as an adaptable solution to health systems without starting from scratch. So this would be it. If you want to partner with us, of course, we're looking for implementing partner. We start to do this, for example, with MSF in Ukraine. We are looking for funders. We are looking for academic institutions to generate the necessary evidence to allow us to make the advocacy, and we're looking for policy advocates. So feel free to flash the QR code if you have an interest. Otherwise, I will be in the room. Thank you for your attention.
Yeah, okay. Thank you very much, Martin, for this interesting pitch. It is my pleasure now to invite Sean Blaschke from UNICEF Chief of Digital Health, who will talk about the last child first, digital health, and the NCD agenda. Please.
Fabulous pleasure not only to be here today, but speaking in between such great sessions, pitches, and hopefully bookending the inspiring introduction that my colleague Dr. Alain Labrique provided. And I'm going to try to take the digital public infrastructure, the foundational investments from the other side, starting with the child, working back up to the national systems. So let's start with the child itself. The NCD agenda is really critical not to be looking at this from when the actual issues start, but from a life cycle based approach, and really looking at it from early childhood on up. Looking at this in terms of everything from air quality, nutrition outcomes, physical activity. This is what really defines the rest of the life for many children as they move through adolescence, child adulthood, and up to adulthood. I mean, we already know that the cost for prevention vastly exceeds the cost for treatment by a 10-to-1 margin, so I won't belabor that. Just looking at this now from the mental health lens, because this is again often missed in broader NCD discussions, and looking at the treatment gap for adolescents, which is one of the largest issues that we're seeing today. The burden, 50% of mental health conditions start by the age of 14, 75% by the age of 24. So this is really a epidemic that really starts in childhood and adolescence. 1 in 5 adolescents experience a mental health condition every year. 250 million young people globally live with a mental health disorder. And the treatment gap is just as scary as the burden, with up to 90% gap in LMICs, where the need is the highest, and with still limited evidence around the digital base for MHPSS in LMICs. Now, we have great evidence on the NCD side, though, that we can build off of. Some of the data up here is from a report from the UN NCD task force. I mean, the return on investment is compelling isn't even a strong enough word for this. A $19-to-1 investment in outcomes, 24 cents per patient per year in telemedicine, mobile messaging chatbot saves 2 million lives, 7 million hospitalizations averted, and almost 200 billion in savings. And so this should be a no-brainer for not just Ministries of Health, but Ministries of Finance, that this is an investment in the population. 74% of all global deaths are caused by NCDs, from a WHO report as well. And an older report from 2011 that was cited about 5 years ago in the UN NCD report, $47 trillion could have been saved by 2030 if we had combined NCD with a mental health psychosocial support component and leverage digital tools in that. Good news, digital health is moving fast. The bad news is that we're leaving many children still behind. But we have some foundations to build off of. 120 countries now have a digital health strategy. We're seeing significant investments in a lot of the underlying last mile systems, from disease surveillance to community health platforms that provide the basis for many of the services that we heard already and we'll hear later today, which could be integrated into and built off of these emerging foundations. And we're starting to see increased political leadership with explicit commitments to children and NCDs. Now, it's not all good news. Where do we have to go? And hopefully this is a call to action for some in this room. 83% of countries with a digital health strategy do not have a costed roadmap or financing plan. A strategy without a plan without costs, and a budget does not get financed. It does not get scaled. It does not get sustained. So that's a massive gap. That 83% number is, to me, still shocking, but this is low-hanging fruit. This is something that can be addressed in a relatively short period of time. NCD-specific digital tools are still not being designed with and for children and adolescents. Integration of mental health and NCD data has not been integrated into all health management information systems, and age-appropriate prevention and early identification systems are still lacking. This is going to be made worse with all the AI tools coming out if we don't move fast to address it. Going back, keeping the focus on the child, digital health tools only work if the most vulnerable child can use them. We have to stop designing for the middle, and we have to design for the edge cases. And again, I said I was going to bridge Alain's talk, where he talked really about the need to invest in national digital health architecture standards. We need to go all the way down to that last community, that last village that isn't being reached. And that means device affordability needs to be addressed. Most of the devices are still built for people in this room with specs that are too costly to provide value for most people in rural communities. Connectivity is a massive gap. It's not an infrastructure gap anymore. We can literally connect every single child, every single health center on the planet, but planning, financing, investment, this is the real gap that's preventing us from using this last mile backbone and connecting every child. And then there's that soft part of the digital infrastructure that, again, often gets missed. Digital literacy. If young people, if frontline health workers are trained only on how to use a software application, we're missing how they operate safely in an online environment. If we expect our frontline health workers, our frontline child protection officers to deal with highly sensitive personally identifiable child data in an online environment where they're constantly being phished for information, great, they can use the telehealth platform, but they're not keeping children's data safe and protected online. So matching that digital literacy with strong online safety components. The window really is now. I think this is something we've heard a few times. We don't have time to wait. Three kind of key points that hopefully people in this room can take and bring with them as you go back to your organizations, the countries you work in. One, as I mentioned before, we really need to advocate not for digital health strategies, NCD strategies that are digitally driven, but bringing the digital world into the program public health world. I want to see immunization strategies, child survival strategies with digital embedded in it and not the other way around. But that's not enough. Again, 83% of countries lacking that costed roadmap is a wish list. It's a wish list that either doesn't get funded or gets funded 10 times by different donors, and we end up just wasting and throwing away money. Neither of those are acceptable. Donors and partners, we need to align reporting, coordinate investments. We have the 2025 declaration. Use this as an opportunity to close the gap between strategy and implementation. And finally, with the global community, everybody here today, recognizing that reaching that last child, that hardest to reach child, is both a moral imperative, but also the hardest and most important systems challenge. This is where, again, architecture comes in, policy regulations come in, the soft components of digital literacy, last mile connectivity come in, and we need to pair the exciting app work that colleagues here are presenting with the harder policy implementation and financing work to meet halfway. Thank you very much.
Thank you, Sean, especially highlighting the visibility of children in the digital health world. That's a great point. Now we move on to the panel discussion for this track, From Promise to Implementation, Digital Health for NCDs and Mental Health. It is my pleasure to call on stage the panel members, Jackie Oguto, Associate Director, Digital Health Solution, World Diabetes Foundation. Ken Carswell, Mental Health Specialist at the World Health Organization. Lourdes Castro, Project Manager, Chronicus. And the moderator for this session would be my good friend, Marina, please come on stage.
Thank you very much, Kallol. Well, I have the honor today of moderating this panel, and the aim of the discussion today will be to explore how digital health solution can move beyond the pilots and become really scalable, equitable, and also integrated into the health systems. So we'll try to look a little bit at what's working, but as well at the challenges that remains, and also the partnerships and policy shifts that are needed to move forward. So now, maybe in terms of implementation realities, so as many of you said this morning, so digital health transformation is increasing very fast for NCDs as well. And Jackie, well, you mentioned the Diabetes Compass initiative, which is now active in 3 countries and as being part of this shift as well. So can you tell us a bit about the objectives of this initiative, and as well what worked well and what surprised you most maybe, and general key reflection from the implementation?
Thank you, and thank you for the invitation to be on this panel. Yeah, the Diabetes Compass initiative was actually a response to the NCD challenge that we've had about today. I think everybody mentioned it, you know, Martin, Antoine, almost 70% of people, 70% of mortality is because of NCDs. Cardiovascular disease especially is the #1 killer. We've been working in the diabetes space, and that's significantly on the rise. Up to 80% of those who have diabetes, which is 600 million now globally, 80% of those live in low and middle income countries. So in order to address this challenge, we had to think about, you know, how do we explore innovative approaches? And digital health here offers an opportunity. So there was a demand from our partners, from country partners, to explore how we can do that together. So in collaboration with the 3 countries that you have mentioned, Malawi, Tanzania, and Sri Lanka, we've been on a journey to explore how we can address the vulnerabilities on the care pathway. So looking at early detection, what can we do for community health workers on the front line to help them screen patients and refer them to care? When they get to the facilities, how can we facilitate the digitalization of, you know, right from the workflows that are used for clinical care, and actually not just capture data for reporting, but for data use and decision support. And finally, aggregating this data so that it can make sense for the policymakers. So really looking at that entire cascade. That's the journey we've been on. And it's been a suite of solutions that have been built, context-specific, selected by the governments, aligned with their strategy, in fact, embedded on existing infrastructure, because there are systems in place. It's only that NCDs have been missing, the workflows have been missing. So we worked with them to build these existing workflows into the existing infrastructure. A lot of learnings. It's been a long journey. I think one of the things that has been encouraging was to see local ownership. And that's really come, one, because it's aligned with the governance, it's embedded in the national strategies. The other thing that has been a key insight is really just ensuring that you know, those who use the solutions are part of developing it. And lastly, I can also say that I think a big surprise for us was just seeing how huge the infrastructure gaps still exist. While the promise is there, the reality, especially in the most vulnerable spaces where we work, still persists. Connectivity, just general public infrastructure, and that's an area where we still need to focus on. Yeah.
Well, thank you very much, Jackie. And I think, well, a lot of learnings, as you said, and I think the aim of the panel is also this, is to be able to share a little bit more about, well, your work and also what everyone here in this room has been doing. So now maybe Ken, well, You mentioned that WHO has been leading development of scalable digital mental health interventions, like step by step. Well, we heard about it this morning as well, but for people with depression, what would you say are the 3 most important lessons from designing and implementing this intervention across different countries?
Great, thank you. Yeah, and first of all, I want to say thanks to the organisers. It's wonderful to see mental health focused and presented so well as part of the discussions today. Before I go into the 3 lessons, I just want to briefly describe some of the interventions, because that's important for the 3 lessons. So you've heard about Step by Step, which is an intervention for depression that was developed in partnership with our colleagues in Lebanon. And then we also have another intervention called Doing What Matters in Times of Stress, and I have it here. Now, this started life as a self-help book, as you can see, and was then later adapted into a digital intervention. Now, these are 2 interventions that we've developed at WHO. There's a third, which is undergoing second testing in an RCT, and will be released later this year if it's effective. Now, I guess that's one of the central things, the lessons, is with all of our content that we've delivered, we've taken very much an approach that's content-based, rather than actually focusing on the technology itself. So really the first lesson is that content is key. The interventions we develop, they use sort of simple, illustrated storylines where people seek help for common mental health conditions, depression, psychological distress, and similar. And it means that all of that content, which we release under Creative Commons as open access, it means that anyone can take it and adapt it to their own system and their own digital system. So for example, we've seen WhatsApp has been adapted into, Step by Step has been adapted for WhatsApp and is now being delivered in India. Step by Step is being delivered across a different system in Thailand, and we have the ongoing dissemination and implementation in Lebanon. So having content that's evidence-based and tested and available, I think, is a key to aspects of scale. One of the other key lessons is really about partnerships. We couldn't have done this without partnership with our colleagues in Lebanon, many universities and many countries. It gives you the ability to both look at implementation and research and following guidelines and expert consensus at the same time. It also gives you the ability, and this is absolutely key and critical as well, is involvement of communities and people with lived experience throughout the whole design process. So that's been another key lesson, has just been, it really is a large team and involvement of the communities that it's aiming at. I suppose the third lesson I would say is really about integration and implementation. So the first thing is that self-help within mental health systems isn't a solution itself. It always needs to be embedded within a system. I sometimes see us rushing towards the new technology as this is going to be the solution, and we can provide people access to chatbots, and that will all be that's needed. But what we know from the evidence is that unguided self-help can work and is effective at a population level, but if you pair that with guidance, it is far more effective. And there will always be people who will require more support, so it really needs that embedding within the system.
Well, thank you very much, Ken, and also to highlight how locally adapted content is really needed, as well as local, reliable partnerships. And we'll talk about integration and implementation just after, but maybe to bring Lourdes in the conversation as well. Well, you presented Food Selfie project earlier in this tract, and of course I know that moving from a research prototype to something really embedded into the healthcare system is never really straightforward. But from your personal experience, maybe what have been the main implementation challenges so far, and also what would you need to change in order for this to really work sustainably within the health system?
Okay. First, thank you for the invitation in participating in this panel. So I think that building the AI model is the easy part. The real challenges is to integrate these tools in our health system and the real life. No? So we have faced 3 implementation challenges. So the first is about the health literacy. The second, about the fragmented care system. And the last, the digital literacy. For the first, before we start to teach our participants to use the app, we need to explain it about the diabetes complications that like diabetes foot. So few people with diabetes checking this, their feet. So this is the first barrier. So for the second, about the fragmented care system, so in Peru, for example, the specialist in diabetes foot are in the hospital, not in the primary healthcare level. But this is a big problem because for people with diabetes to see the specialist take approximately 3 months. So it's very difficult. What happens if the Alerta PS app, for example, identified a lesion? What happens next? No? So about the digital literacy, the majority of the people with diabetes are older and use older cell phones, limited storage, and need to support, digital support, for example, caregivers for use the cell phone or use the app. So this is experience taught us that technology alone is not enough. We need to co-create with the stakeholders, with people with diabetes, with people affected, caregiver, healthcare professional, decision makers too. It's necessary to integrate into health system. Thank you.
Well, thank you, Lourdes. And I think what you just mentioned in terms of co-creation brings us very nicely to the next topic I actually wanted to talk with you, is also what is it that really makes, in the end, these approaches work? When we talk about co-creation, policy alignment, but as well, sustainability considerations, we often say that people-centered design is not just the principle, right? Is what really helps solution then to endure and to scale up. But now, Jackie, well, you described the process, the fact of in our discussion earlier that the co-creation was really present throughout the process, but also painstakingly slow. So why is this the case? And also, what, in your opinion, were the turning points maybe that made the ownership shift possible?
Yeah, thank you for that question. And you're absolutely right. I mean, it was a great learning for us as an implementing partner as well. Just how important it is to take time and to be patient. And right from the beginning, in the early phase of the project, we actually invested a lot of time in the problem understanding, really to listen at what is the challenge of those with lived experiences, those who are treating them, the caregivers, community health workers, and involving them in that process in really understanding, and together with them designing what the solution could be or could look like. Selection of what the platforms would be, ensuring that they are locally owned and can be sustained. What we saw with that is actually just fostered a strong buy-in. They own the solutions, even the way they talk about them now. It's not about us, it's about the government of Malawi, Tanzania, and Sri Lanka developing this. So I think it's a great learning to see that if we really want to build something that lasts, as much as it is slow, that is really what fosters the buy-in. So it is worth it. We cannot rush longevity and sustainability. The other thing is also ensuring that those who build the solutions, it is the local developers. None of these solutions was imported into the countries. They are solutions that actually already existed. And whatever was built that was new was very much aligned with the national blueprint as well. So I think, generally speaking, co-creation, to really practice true co-creation, you have to involve right from the beginning, from the design phase, and bring them along the journey of the development up until the end. Then there's true ownership.
Thank you, Jackie. True ownership, I think, is a key message here to remember, and maybe we can build on that as well and move to Ken. I know that WHO has now developed, well, the 3 digital intervention for psychological distress, and that one key success factor was the fact of having human-centered design approach from the very beginning. Can you walk us through briefly through the process, what it looked like, and also maybe what it produced that other approaches maybe didn't?
Yeah, sure. So we need to go back to the start of this, really. So when we started our work on digital interventions, particularly on Step by Step with Rabia and colleagues in Lebanon and Melissa Harper, who is here, we were starting with developing an intervention. So at that stage, there was a lot of involvement of colleagues in Lebanon, community feedback, people thinking about the cultural considerations of it, the language, what sort of techniques we should use, and similar. So we've always had that aspect in the design of our interventions from the beginning. But in 2017, 2018, when we started developing a chatbot, so it's a non-AI chatbot for youth mental health, we decided to take a bit of a different approach, and we hired a human-centered design expert to sort of help us with it. And it was really interesting going through that process, because it sort of took us from what we'd been doing before, which was a lot of consultation, to actually starting with the idea of what problem are you trying to solve. So we'd started with the idea of we're going to build an app for youth and they're going to use it. And the person we're working with was very much like, no, that's not where you start. You start with the problem. You then consult with your groups, you understand their lives, you understand the technologies that they're using, you then start prototyping. And that shifted us from this idea of an app to a non-AI chatbot. And it was a fantastic experience, and I think really as a result of that, it's led to probably one of our most engaging interventions. And had we not, so it's more of a I suppose a conceptual mindset to take with it really, rather than a clear methodology, but just having that approach of thinking what problem you're trying to solve and prototyping, we found hugely helpful. And just a quick plug, so we're releasing a manual on the 1st of June on our self-help programs, which has all of this information in it. So
excellent.
Look out for that.
Well, thank you, Ken. And I think, well, you said this methodology in terms of, well, local language as well, consult with the different groups is something I know you lured us with the Food Selfie project. Well, you're working a lot with patients, healthcare professionals, but as well decision makers. And according to your experience and perspective, what did these different groups in the end teach you? And how have you approached communities where digital literacy or access to technology might be limited?
So each group teaches different something. It's not possible to learning in the literature. It's not writing in the protocols. So the patients touch us the importance to designing the app on their needs and cultural context. For example, the medical or clinical lesion we call featured, but for the patient don't understand what is features. They name, for example, in Spanish, rajadura or crack. So the small difference influence in the development of the app. Also, they helping co-create the app, include different functionalities for the app. For example, they request an educational component, not only with information about diabetes. We need more information, mental health, nutrition, and more. Other about the results, we asked to the explanation doing the real medical doctor, no icon, no cartoons. And for understand the results, they suggested include a lighting system with colors, with icons to understand and measure the rates of the lesions. About the professional health cards, they asked to the app Alain for the workflows and don't add more work for them. And also request more training in diabetes food, especially for healthcare working in the first level. About the decision makers, so such as the sustainability requires integration in the guidelines, in the policy. So for this reason, we formed the National Advisory Committee during all the project and provide a suggestion brief to the for the Ministry of Health to integrate the diabetes food follow-up. We move from the designing technology for community to designing it with them.
Yeah, well, thank you, Lourdes, for this example of how you integrate the suggestions that stakeholders you co-create with are recommended. And I think as we near now as well the end of our discussion, I just would like to invite one final reflection from each of you, from your perspective. What is one concrete action maybe that governments and as well donors should prioritize in the next 2 years to make really digital health solution in NCDs and mental health more sustainable? Maybe we can start with you, Jackie.
Yeah, I think I'll reiterate what's been said actually earlier today, that really it's coordination and not just talking about it, but doing it. How do we coordinate or strengthen the coordination mechanisms of funding so that we can channel these limited resources, especially in NCD, to the big bets that will actually move the needle going forward. And I think also it's for us to consider, I know often we are not fans of pilots, we talk about it here, but not all pilots are built equal. You know, there are pilots that have been tested, that have been proven, perhaps channel the investment also towards those pilots. In that vulnerable phase of scaling, those pilots that have potential, like we've heard about the food selfie, they have potential to have a huge impact into scale. So not all pilots should be discarded. Those that are worthy of moving forward, I think that's where we should also put our investment in as well.
Thank you, Jackie. Ken?
Yeah, I think probably similar. I would say really about integrate, so integrate with different platforms. So for example, we could put a stress management guide on some of the NCD platforms and similar. So really think about that integration piece, cooperation between different aspects of health. And I must also say, I mean, my big learning this morning, a big reflection has really been about the importance of policy and also having the central systems there to back up the technology. And also the importance of designing for the communities and with the communities.
Absolutely. Yeah. Thank you, Ken. For you, Lourdes?
I think the governments and donors are ready now how to fund innovations, but what remains unresolved is how to fund what comes next. So over the next 2 years, I urge the governments and donors to provide a terms funding until digital health is fully integrated into health system, including training for healthcare professionals and people affected too, and co-create with the stakeholders. This is that the design of the app is central of people. This is very important. Thank you.
Thank you, Lourdes. And I really feel, well, that this discussion also resonates with what we are doing at the NCD Policy Lab in terms, you mentioned the importance of policy and trying to bridge science to policy, definitely, and also tackling implementation gap and co-creating context-adapted solution through very close collaboration between researchers and policymakers. And I would like also to just emphasize on what you said, Jackie, in terms of, address this duplication of funding and efforts as well, because it's really a key structural problem we're having and we need, to emphasize and strengthen the multi-sectoral collaboration, definitely. So maybe just to wrap up this panel today, I feel maybe the key messages, it's really to focus on real-world implementations, to keep people at the center, designing with the users, definitely, embedding tools into the health systems, and as well aligning, as you, all of you mentioned, aligning with policy and financing really from the very beginning. And in terms of today's call of action, maybe, if we can say that, is really, move beyond pilots, work together and turn evidence into sustainable, but as well system-owned solution that will, in the end, truly improve NCD and mental health care. So, thank you. With that, I would like to thank you very much. Thanks our panelists for this exciting discussion, and hand over to my colleague, Kallol.
Thank you, Marina. Great, intriguing panel discussion. Now we move on to a two-word session, which has two exciting words together: speed and dating. So to run us through that, I welcome Jeroen Maas, Director Access to Care Technology and Partnership at Philips, and a core team leader for the Digital Care Connected Coalition to coordinate this section. Jeroen, all yours.
Yeah, thank you. Thank you, Kallol, and good morning. Yeah, I'm going to try that same thing that we heard this morning. I'm going to do it again. Good morning. Well, we're almost getting there, but keep on building the spirit, because in this session, we will need your input. You'll get something from the stage, but you're also supposed to give something back. So can we do it once more? Good morning. Super. My name is like you just heard, Jeroen Maas, working for Philips, but here I'm with the head of the Digital Connected Care Coalition. I'm going to give you a very brief introduction, but just before, I'm going to ask the pictures to go forward already to have a smooth transition later. Sorry. If you could just stay there. Super. Didn't recognize you. Apologies. I'm looking into the lights, so you just came out of it. The Digital Connected Care Coalition, I want to give you just a brief introduction, but it has never been easier to introduce us than this year. It was in 2019 that the number of private sector parties, NGOs, and government-related bodies came together and said, we need to get rid of pilots. The word pilotitis, I think, wasn't coined at that time, but we talked about it. And we said we get rid of the newspaper clippings for our individual projects. We get rid of these a few years projects, and we just collaborate. We bring our resources together to help scale projects. Today, we have a core team of the Digital Connected Care Coalition, led by Philips, the NGO Farm Access, and we have insurers AXA in there, and reinsurer the Swiss Re Foundation. And why is that important? Because we all know, we heard it before, It needs to be integrated. Whatever we design in terms of digital health needs to be integrated, implemented across the care chain, and nobody can do this alone. So really happy to do this here together with the Geneva Digital Health Hub, with you, because one of the things we do is really provide a podium to promising ideas and really build the whole ecosystem. That's what we do today. Speed dating. I really liked the introduction, speed and dating. So what do? We have 3 sessions of 3 pitches of 3 minutes each. And there are 4 elements in each pitch. So one is, what is the problem? The second one is, what is your solution? The third one, what do you need from the audience? So people will be asking you for something. And the fourth element is, what will the pitches give you? What can you get from them? Because we have a pause after this, you can grab coffee, and the pitchers will also be there at the, I don't know what to call it, the hall that you all came through when you came to this venue. So, without much further introduction, yeah, I see you there, my dear friend. Can we, sorry, we start, I think we had some last minute changes because of visa problems. Okay, so we start with Carolina Batista, I think. Please come forward, it depends on the next slide. Yes, so 3 minutes. I'll do relentless timekeeping.
Can you guys hear me? Okay, I have to confess something. It's my first speed dating experience, so I hope I'll do well. Okay, so use here? Okay, so, well, I'd like to start with a question that I think has a lot to do with the previous presentation, including what Alain told us this morning. So what happens when people can no longer distinguish trustworthy health information from misleading information? What is real, what is fake, what is misinformation? We hear a lot of that. So I will follow with another question. Have you ever searched anything online, whether it's health-related or not health-related, or in the middle of a YouTube video, found yourself within minutes flooded with content that sounds scientific, looks credible, but maybe far from evidence-based or based in medicine and public health guidance? So if experts in the room, like you, like many of you that are like leading the way, have a hard time distinguishing quality information from the noise, from the snake oil out there, what does it mean for regular people, for the general public, right? So this question really becomes, you know, how do we build trustworthy health systems that, you know, increasing help people to distinguish what is good, what is fake, how can they maybe test, you know, like we have when we buy anything to eat, we see the label, right? What is the sugar content, what is the fat content? So is there a way that we can work together to ensure that we build this trustworthy health information system? Because increasingly, this is no longer a future problem, right? We deal with that every day, day in, day out. And of course, AI and digital health tools are becoming very quickly the infrastructure for health information itself, right? It generates information, it amplifies information, but also it becomes a very important, and we saw that with great examples, ways to deliver healthcare, right? Whether it's a clinical decision support tool, whether it's a tool that's developed with people that have terrible conditions like diabetes. So I'm here today as my role as a co-chair of the Nature Medicine Commission on Quality Health Information for All, and I'm very pleased because Alain Labrique is one of the co-chairs, along with Ozgi Tunsalp from now, who's also now in Antwerp. And my question to you today, my invitation is really, you're leading the way in digital health transformation. You're creating tools, you're close to people, you're close to realities. So come talk to me. I would love to bring you and explain and also profile what you're seeing on the ground and maybe publish your experiences. We need this real world evidence because we know that AI speed is so fast and we're always trying to catch up. But what if we get together or go almost at the same speed? So my invitation to you today as the co-chair of the Nature Commission is really come to us, let's collaborate, let's tell the stories, let's tell your success, but also let's share the failures because we all learn from it. Thank you so much.
Thank you, Carolina. Beautiful. And thanks for the invitation to the audience, indeed, to share what has been learned. So that
maybe just to say that the role of this commission is not to be purely academic and have a wonderful reports that I hope we'll have at the end. We've been publishing things already, but we really want to publish your experience, but also use your digital tools to share good quality information for all. Thank you.
Thank you. You did it very smoothly, just getting in some extra time. Okay, without further ado, I want to introduce the second picture of this session. Dino Rech, CEO of Terre in South Africa. Welcome to stage.
Thanks very much. It's wonderful to be here with you all today. I also got married before speed dating was a big thing, so like you, I was very excited to try this. So let me quickly move on to my slide. I represent a technology company called Terre, and your talk was a great segue. We are looking at how to provide quality, trusted information as a form of improved primary healthcare triage. So how many times have you had an instance where I'm an ER doctor by training, I would see someone at the emergency room who spent a lot of money who could very easily have solved this with the correct information at home, trusted information. Or in a developing world setting where I've worked a lot, you have people waiting all day in long queues at clinics for a simple piece of healthcare or primary health advice. There's a lot of inefficiencies in that primary healthcare flow, and we believe that self-care platforms and self-care tools integrated within a primary healthcare ecosystem with the digital capabilities we have today can be extremely valuable. So this includes, as an example, an AI companion that we've customized for 3 countries in Southern Africa, South Africa, Zimbabwe, and Mozambique, where patients at clinics get onboarded by healthcare providers and have a 24/7 source of trusted information at home to talk to and access. This is linked to telehealth, where there are AI-enabled dashboards, and healthcare professionals sit behind those, and when they see harm flags, someone talking about mental health distress, someone talking about self-harm, someone potentially at risk for gender-based violence, it flags it to the human, and the human can reach out again through either text or a phone call with nudges to say, we're here to support you, how do we triage you into your nearest healthcare access point? That could be a private sector pharmacy, it could be a government clinic, it could be the telehealth consult in an extended way. So that's how we're thinking about reimagining this offering of primary healthcare and eliminating a lot of the inefficiencies in the system. What are we looking for? So we've tested this for 3 years in Southern Africa. We have 150,000 users currently with the Departments of Health in South Africa, Zimbabwe, and Mozambique. And we're looking for more research partners and implementers on the ground. The tech platform is built on a fairly big $5 million underlying investment. Each customization by country for language and to integrate in an ecosystem costs around $300,000 to $400,000. And we're looking for both implementing partners that onboard and lead in country, as well as research groups. One of the big gaps continues to be cost value analyses. So if you are able to improve prevention, if you are able to improve adherence and care, what are the cost benefits of that ecosystem shift? So anyone in the room, academic partners, implementing partners in country, please come speak to me after this if you're interested, and thanks so much for the opportunity to talk about it today. The QR code has a small video that you can watch later that walks you through the platform and how it works. Thanks.
Thanks, Dino. So you've got your requests and offers, requests for lessons learned, offer to have it published. Requests for more research capacity, implementing capacity, and the offer a platform. Please come and see the pictures in the hall. We'll be back at the end of the next session and the third session. But for now, I'd like to hand it over to Marina, and we'll speak today. Thank you.
Thank you so much, Aaron. What an interesting speed dating session, but we're now coming to an end of this first track. It's time for coffee break. So you have until 11:15, 11:20. Yeah, 11:20 approximately. So please take this time as well to connect with the speakers, to ask all of your queries, and coffee will be served in the hall. So please help yourself. Have a great day. Thank you.